So what are our treatment options? How do we help our friends, our family, our patients who struggle with alcohol use disorder? Some people say that the hardest step is the first step, and I certainly think it does not have to be. This should be an ongoing discussion with your friends, with your family, with your patients, trying to understand how much alcohol they're consuming, trying to educate them on what is a safe amount, and if they are consuming more than a safe amount, what are our options to help them? Do they want help? What are their drinking goals? Historically, there's been a lot of stigma associated with mental health and specifically with alcohol use disorder. I think a lot of this stigma comes from the challenges that we faced treating this condition. Historically, people felt that if they were unable to stop drinking, it was a moral failing. People may have not understood that there is a physiological part of alcohol use disorder, and there may be reasons why they are struggling to stop. There may be biological factors, there may be social factors, there may be psychological factors, and these are all areas that we can tease out and try to come up with a tailored treatment approach for an individual. Historically in medicine, our approach to alcohol was counseling on abstinence. There's programs such as AA, 12-step programs, medications that we felt were only used to support abstinence, but I think we can all reflect and agree that abstinence as a goal for measuring our success here, probably hasn't been all that successful in the past. The new paradigm shift in terms of treatment and the new evidence-based approach to treatment really supports a patient-centered approach to treatment. And this means understanding what the individual patient's drinking goals are. Does the patient want to stop altogether? Does the patient want to quit cold turkey today? Does the patient want to cut back on the number of days per week they drink? Does the patient want to cut back on how many drinks they have in one sitting? Does the patient only want to continue drinking in social situations such as birthday parties or celebratory events? We are now finding that you have the most success with treating alcohol use disorder when you're taking a patient-centered approach and you involve the patient in the goal-setting process rather than forcing abstinence or focusing on abstinence as the only measurement of success. Certainly, this conversation continues once the patient reaches their first goal of reducing the number of drinks per day. At the next office visit, if you're a family physician, maybe the patient and yourself agree to take us one step further, now cutting back to drinking every second day. From there, cutting back to only weekends, etc., etc. I think by respecting the patient's wishes, focusing on small, measurable, achievable goals, you and your patient are more likely to find success in treating their alcohol use disorder while maintaining a therapeutic relationship. So what are our treatment options? I think first and foremost, I want to refer back to our biopsychosocial model. Treatment plan should be individualized for a patient and should be multifaceted in the sense that we should be approaching treatment from a psychological standpoint, from a spiritual standpoint, from a social standpoint, as well as a biological standpoint. I certainly think that there is equal benefit from all of these aspects of treatment. I think here today I'm going to speak more about the biological component, specifically medications. Obviously, as a prescribing physician, this is something that I have more experience with than other members of the healthcare team. So out of the medications that have evidence to support treatment for alcohol use disorder, there are currently 4 that are approved by the BC Centre of Substance Use, which is one of the set of guidelines that we use here in BC to help guide our treatment of this disorder. The 4 medications being naltrexone, acamprosate, gabapentin, and topiramate. I'll go through each of these individually and discuss some reasons why we might choose one over the other when finding a treatment option for a specific patient. So naltrexone. Naltrexone works by binding the reward receptors within the brain, helping prevent the euphoria that comes with alcohol consumption, helping prevent binge drinking, and hopefully reducing the number of heavy drinking days or heavy numbers of alcoholic beverages someone drinks in a setting. I think about using this medication in someone who suffers from binge drinking or blackouts, or who tells me I can never have just one drink. It's a medication that can be taken every day. It's also a medication that could be taken when they know they're going to be exposed to the situation where they may tend to drink heavily, such as getting together with their friends or in a Christmas party setting. Naltrexone is also a medication that's safe to start while someone is still drinking. Second medication I'd like to speak about is acamprosate. So acamprosate is a medication that has good evidence to support abstinence. It's often started within the first week after complete alcohol cessation. It helps achieve abstinence by interacting with various parts of the brain and preventing relapse. It also has the tendency to reduce some of the symptoms of anxiety, insomnia that are associated with those first few weeks of stopping drinking. I think it's important to distinguish the difference between acamprosate and naltrexone, being acamprosate will not help people stop drinking if they are drinking, so it's really only intended to be used when someone is not currently drinking. Third medication would be gabapentin. Gabapentin acts by binding to the same or similar receptors in the brain that alcohol does. The GABA receptors, which when alcohol is not around, are responsible for causing some of the withdrawal symptoms, including tremor, anxiety, insomnia, agitation. So by prescribing gabapentin, typically at a dose of 600 milligrams 3 times a day, this helps by binding those receptors and reducing those symptoms of anxiety, reducing the symptoms of agitation and insomnia, and allowing the brain more time to return back to balance or homeostasis without chronic alcohol around. This medication certainly can be reduced and is not necessarily intended to be long-term. Like acamprosate, this is a medication that's typically used after the patient has abstained from alcohol. Fourth medication would be topiramate, typically used in people who have a history of significant cocaine or stimulant use, who struggle with labile emotions, anger, violence, or have a history of PTSD or migraines. It helps promote alcohol reduction and abstinence by acting on the same receptors that are involved in the dopamine reward and reinforcing pathway involved in addiction. There's also been some studies that suggest its pathophysiology may lead to reduction of symptoms of anxiety and depression in the early phases of abstinence. So these 4 medications can be used effectively, safely, at a reasonable cost and reasonable tolerability to our patients struggling with alcohol use disorder. It is important to remember that each individual medication is different and the indications are different. So it's important to understand the patient factors, the symptoms they're experiencing, and what medication might be best for them to help them achieve their drinking goals. When looking at the guidelines from the BC Centre of Substance Use, both naltrexone and acamprosate are considered first-line agents. That is because they have the most robust evidence supporting their use. I do want to make the point to distinguish the concept of what's first line and what might work well for your patient. If my patient's goal is abstinence, although naltrexone is first line, that doesn't mean it's the right medication for them, since their goal is abstinence, and we know that naltrexone doesn't have the best evidence supporting abstinence. Rather, it's meant to reduce binge drinking and euphoria. Similarly, if the patient struggles with binge drinking once a week or once a month, taking acamprosate every day, although it's first line, isn't going to be the best choice for this patient. On that same note, gabapentin and topiramate are both second-line agents. If I have a patient who's struggling to continue to abstain from alcohol in the first week or so due to symptoms of tremor, anxiety, agitation, insomnia, gabapentin may be their best option. So I think this really illustrates the importance of choosing the medication that's right for the individual patient rather than just following a flow sheet or a recommendation from a specific guideline. It certainly is important that we understand why and when each of these medications is best used.